Roundtable with the doctors from Everett Bone and Joint.
That's right, Maury. Again, we have Dr. Clay Wertheimer, Dr. Howard Barker, and Dr. Todd Havener with us tonight. And we're going to start off with the knee. And my first question is a very common injury, a tear of the ACL, or anterior cruciate ligament. And set that up anatomically. Where is it? How does it become torn? And what's going on there? One of you guys go ahead and take it.
Okay, I'll take this one, guys. The ACL is a rope that connects the two ends of the bones of the thigh bone to the shin bone and holds the knee together and stabilizes it when people are changing direction, cutting, stopping, doing things like that.
And to tear that, usually it's some kind of ballistic event. There's got to be some kind of speed or activity.
It's usually, Shannon, a change in direction that does it. So when the foot is planted and the rest of the body goes another way, and the shin bone gets shoved forward with respect to the rest of the body, that's when the ACL can rupture or tear.
Okay, and that's pretty painful?
It can be. I mean, it's real. I don't know about you guys, but in my experience, it's interesting talking to people who have suffered ACL injuries. First of all, it's often loud. Like people on the sidelines can hear the pop.
Like a pop.
Yeah. When it happens, it is often loud. And the pain is variable. If it's an isolated ACL, if all that happens is an ACL tear, then oftentimes there's not a lot of pain. But the person, the knee swells almost right away, and the person just can't, stand up on that knee. It feels like it wants to give out or give way. Is that your experience too?
I've seen it especially with skiers who don't have a lot of pain. They have the isolated ACL, and it swells up on them but doesn't hurt very much.
But is it real common just to tear your ACL only and not get other areas of the knee involved, like the meniscus or a muscle strain or anything like that?
Usually, Shannon, the ACL is not damaged in an isolated fashion because that trauma that is required, the amount of force that's required to rupture or break the ACL often hurts other things inside the knee. And typically that other thing is the meniscus or the cartilage pad in the knee. Other ligaments can be damaged as well.
So go ahead, Maury.
I was just going to ask the question. In football, does it matter what kind of turf you're on? I mean, is one turf like, remember when AstroTurf came in? Does that make it worse? Or
That's a great question, but I don't think it does. I mean, the studies that I've read or looked at, there hasn't been, as far as I know, a higher rate of injury on AstroTurf or artificial turf compared to grass surfaces.
Okay.
Any thoughts on that, Dr. Havener?
No.
Okay. Just want to make sure. Here's the question.
He's got a lot of thoughts about hands.
Yeah. We're going to talk to him. We're going to talk to Dr. Havener.
We're going to save him for hour 4. Hour number 4.
Yeah. Okay. Yeah. So here's the question: why are we seeing an increased incidence of ACL injuries in the female population? Have you noticed that over the years?
Oh, yeah, I think all of us have noticed that.
So tell us what's going on there and your thoughts.
My thoughts is it's just a lot. Number one, there are a lot more girls playing a lot more sports. Back when we were kids, it was mostly a boy thing to play Little League or or organized basketball or football. Now girls, with Title IX and all that stuff and the changes in our society, girls are playing sports just as much as boys. And kids in general are playing a lot more sports, a lot more seriously, and a lot more frequently than they used to. So consequently, we're seeing a lot more young kids with serious injuries like ACL. It happens that girls are getting their ACL torn more than boys, though. And we have some ideas about that. One idea is that it's just the way that girls land when they land on their knee. They tend to land from a jump with their knee extended or straight. And when the knee is straight, that puts more strain, more force on the ACL. So the ACL is more prone to tear. Another theory is that it's a hormonal thing, and that may be a contribution to it, that hormonal shifts can have an influence on how lax or how tight the ligament is. So in some of these adolescent girls or young women, that may have a factor. And the third is just the way the woman's lower extremity is put together. Women's pelvises tend to be a little bit wider. They tend to be more knock-kneed than men. And consequently, as a result of those things, the force on that ACL is greater than in a man's knee when a woman plants or twists or drives the lane.
That's interesting. Are you learning anything, Maury?
Yeah.
This is incredible.
I thought it was because they were made of sugar and spice and everything nice.
That's a good try there.
I just learned a lot.
So I'm going to kind of create a little opinion here, and I think as a physical therapist, my tendency is to think it's based on the way they land. And is there any research that has shown teaching these kids, especially young girls, how to land at an early age, that it decreases the incidence of ACL tears? Is there anything done there?
There is. There's one college study done on basketball players that show that they can decrease their risk of an ACL injury. The problem is, how do we train half the sports people in America to do that?
But when you're talking about landing, it's the landing where you're loading, so that's the eccentric phase. Can someone explain what I mean when I say eccentric and landing?
Well, eccentric, I mean, we're all eccentric, right? Eccentric loading means a muscle contracts and creates tension. But another way a muscle works is actually by going from a contracted state or a tight state to a gradually loosening state. It's like paying out a tight rope.
So the fibers aren't shortening, they're actually lengthening.
That's right, but they're lengthening under tension.
Right.
And so the force on the muscle is actually greater when they do that. So that's like when you're going downstairs, you actually work your quads, those muscles in front of your thigh, going downstairs more than you do going upstairs, or downhill more than you do uphill, because that's an eccentric thing. Your quads are kind of paying out the rope and paying out the tension to lower you down that slope.
So if I have a soccer team of a bunch of 12, 13-year-old young ladies, I should teach them how to jump off a box and land?
Yeah, I think that's a good thing to teach. You probably should teach that to any young kids. For some reason, boys tend, maybe it's somehow patterned, but I think any young athlete should be, that should be part of their training and part of their exercising in terms of, landing with a bent knee and landing to absorb that impact.
One other thing anatomically, is there any difference, female versus male, the end of the femur bone, the intercondylar notch area?
Do you guys want to take that one? I've been talking a lot.
Oh, talk away, Clay. You're doing great.
The femur bone, the thigh bone, is kind of like the drumstick. When you crack open that turkey on Thanksgiving, and the end of the drumstick has a notch. The notch, there are two condyles, or two kind of bulbs on the end of the bone.
The bumps on the inside and outside of your leg bone.
And so there's a notch in there, and that's where the ACL lives. And it appears that in females they have a more narrow notch. So there's less room for the ligament. And when the knee extends or hyperextends, the ligament actually bumps up against the edge of that notch and can get excessively strained or tear that way.
How much, in your opinion, how much does that bone, those two bones, so you have the femur and the tibia, how much do they have to move in order to actually tear the ligament? I mean...
Yeah, they've done studies of that, both in animals and in cadaver studies, humans, and it's just a matter of millimeters between what's normal and what's abnormal that can strain that. Just as an aside, too, there probably is a variation in human bone slope and anatomy, and it may have something to do also with the tibial side on females. When they reconstruct ACLs in dogs, they don't do a ligament reconstruction. They actually cut the bone and change the slope of the bone. That's part of the surgery.
Just so everybody understands anatomically out there, that's the tibia.
Yeah, the shin bone.
The shin bone, that's where the thigh bone sits on top of that tibia.
So there may be something to do with the slope of the shin bone as well that's contributing to this increased incidence in females or in certain individuals.
That's interesting. So now we've got a patient tore their ACL, and you're going to do surgery. And so tell us about the procedure and your choice of graft. When I broke into physical therapy, they were using the bone patella tendon bone graft, and now we see a lot of hamstring grafts being used. And describe those two grafts and the procedure and what's your feelings on the use of them.
Okay. Well, first of all, Howard, you're doing more hamstrings now, too.
I do almost exclusively hamstring now. I was trained with bone patellar tendon bone and have shifted more to doing hamstrings. I think people recover faster. I think the graft is just as strong once we get it healed within 6 months, and I think the surgery is easier for them to recover from.
Shannon, just for the radio audience, what we're doing is we're basically replacing this rope that's been torn with a new rope. We can't sew it back together. We found out through experience that sewing that ligament back together is a disaster. It didn't work. The knee got stiff. The ligament didn't heal. The ligament is inside the knee joint, so it's constantly bathed with synovium and with the knee fluid, so it can't really form a blood clot and stick itself back together. So we've given up years and years ago on repairing the ligament. We came to the conclusion it's better to replace or reconstruct the ligament. So you have to rob Peter to pay Paul. We have to find some kind of tissue, some kind of substitute that will be strong, like the original ACL, to substitute for it. So we do now what we call an ACL reconstruction. And currently, the two choices for that tissue to replace the ligament is either the hamstring tendons, those tendons that are in the back of your knee that help bend your knee, or the patellar tendon, the tendon that's right underneath your kneecap that extends down to your shin bone. Both of those tissues in your body are really redundant, they're really strong, and they can handle having some of it removed to be used as the reconstructed.
Everybody's feeling the back of their knees right now, driving down the road. I have an email about bone grafts.
Wow. And we'll get to that email.
We'll get to that email right after we take a break. This is fascinating stuff. It's a orthopedic roundtable with the doctors from Everett Bone and Joint with Shannon and Maury, and we want your phone calls. Give us a call at 425-304-1380. If you have any question you want to ask the doctors, we have them for the next, 45 minutes, half an hour, right around there?
45 minutes.
Yeah. We'll be right back right after this.
Health Matters, brought to you by Integrated Rehabilitation Group on North Sound 1380 KRKO Radio.
Welcome back to Health Matters. We are smack dab in the middle of the Orthopedic Roundtable with the doctors from Everett Bone and Joint. Dr. Wertheimer, Barker, and Havener are with us today. Give us a call, 425-304-1380. This is free medicine advice, folks. I think, are you guys going to write prescriptions later on? I think no prescriptions.
We're just talking here more.
Okay, we're just talking. Okay, just checking. I have a question. We were talking about bone grafts, and we got an email, and their question is it normal to get a graft from a donor rather than the patient? And what's the chances of problems from a donor graft like a cadaver? So.
Todd, this is right up your alley.
Right up my alley. How so? Well, donor grafts compared to patient's own tissue, I think, is never going to be, in my opinion, the same quality. There is a very, very small risk of disease transmission, but that's these days pretty much negligible. Most times, I think the tissue being adapted by the body and potentially healing isn't quite as good as your own tissue. You have potential for rejection. In my hands, I usually use autografts rather than allograft.
How about artificial?
Artificial? That's not used for ACL as far as I know.
No, but even for bone graft like coral or things like that, still it's not as good. The risk of using those things is low, but the quality is much poorer than your own bone.
So just to review, if your physician says I'm going to use an autograft, that means the graft is coming from
you, the patient.
The patient. So you're supplying your own graft. Yeah. If the physician says we're going to use an allograft.
Yeah. So what would make them use a cadaver rather than your own?
Nothing's better, like Todd says, than your own tissue, because your body doesn't reject your own tissue, right? It recognizes it as good stuff and it grows in. But one of the problems with getting your own tissue is it's another surgery. I mean, it's another thing you have to do to the patient to cut something out to get the tissue. And in some cases, allograft or artificial bone graft or bone graft from somebody else, like a cadaver or donor, works just as well. And the benefit is you don't have to carve it out of the patient to get it. So it reduces what we call morbidity or the pain and suffering associated with the surgery.
Okay.
So you have to kind of weigh the benefits. The benefits of the allograft is you don't have to take it out of the patient, but the downside is it may not grow in as well as the patient's own tissue.
So do you give the patient a choice, or you decide?
Sometimes. It's a volume issue as well, too. If you need a large volume of material to fill a void, you usually can't get that from the patient.
I see.
Well, where do you harvest, with a bone graft, where are you harvesting from on the patient? What spot?
Traditionally the spot was the pelvis, the iliac crest.
Or the hip bone, then?
Yeah, well, it's not really the hip bone, it's more your pelvis bone.
Okay.
Where...
I'll take trivia for 1,000, please.
There are other places that we can get it. Like Todd does a lot of hand and wrist stuff. So Todd, you would get a graft from the radius bone, right?
Typically the radius. I also now use proximal tibia for my bone grafts. And in terms of the email, there's in terms of what we were talking about ACLs and stuff, there are a lot of people who are using ACL grafts that are cadaver grafts too. So grafts don't have to necessarily be bone, but can be ligaments. I typically like the radius for most of my hand procedures just because it's right there. I don't have to go anywhere else in terms of making another incision in a different part of the body.
So on the bone graft thing, we use bone graft usually when we want something to heal, and usually it hasn't healed. So we have to go back in there and help it. And we put the bone graft in there to act like slow-growing cement and kind of bring the ends of the bone that haven't healed together. In a ligament graft, we were talking about ACLs earlier, there we're substituting for a structure that's been damaged, and we're putting in a substitute structure. And we've gotten to the point where it's fairly easy, and the morbidity or patient suffering from getting that graft, we've kind of figured out ways to get it so it's not so bad. And most of us, I think, use, in the ACL case, the patient's own tissue to reconstruct the ACL rather than use a allograft or some dead person's tissue that's been donated, a cadaver, and it's been sterilized and clean and preserved. But there's still a chance that the patient's body would recognize that allograft, that other tissue as foreign, and eventually attack it or somehow break it down and not accept it.
What are the circumstances where they'd even use an allograft in an ACL repair? I mean...
Well, again, there are lots of people and surgeons, orthopedic surgeons out there that do allograft surgery primarily because it's so easy. I mean, you don't have to rob Peter to pay Paul.
So you don't have to do the harvest then?
Yeah, you don't have to do the harvest. Like, for a patellar tendon graft, we have to cut the middle third of the patellar tendon out of the patient, and that there are downsides to that. It can cause knee pain, chronic knee pain. It can make your kneecap hurt. It can create a scar that may be sore when you kneel on it.
Is there an age limit to this? As far as, do you do like the grafts for kids and stuff when they tear their ACLs?
Age limit for young, yes, because if they're not done growing, we can interrupt their growth.
Right, yeah.
And so then sometimes we make them wait, or we do another different type of surgery so that we don't have to go through those physeal plates, the growth plates. But for old, I've done one up to a 70-year-old who wanted to get back skiing, and she did great.
And wow. What kind of graft did you use then?
Hamstring.
Oh, you took her hamstring then? Interesting. So,
sign me up.
Yeah, here we go. So we're grafting 101 is complete here. Excellent answers. So
I think that was more of a 300 level course.
That was really good.
Yeah. So
this will be on the test. So
I wanted to find out. So now the ACL's been done. We've repaired it. They've gone through rehab. What are your thoughts on bracing? Because I know 10 years ago, people were going out spending thousands of dollars on these braces, and there was a salesperson in your office all the time trying to get you to use this special brace. Any thoughts on that now? I just don't see a lot of the braces out there anymore. I don't know.
Yeah,
we're trying to create some controversy here.
Okay, it is controversial. There is some evidence that braces can help, but that evidence is pretty slim and pretty much restricted to skiers, actually. The only evidence is in downhill skiers where they claim, when you interview downhill skiers, that they feel a lot more secure and a lot better in their brace. But when you look at the studies that have been done where they put braces on people and stressed and strained their knees, the braces don't really seem to do much, either in protecting the ACL or in stabilizing the knee. So I think most of us in our practice are not real brace-centric guys, and we'll use a brace initially after surgery to help the patient until they get their muscle strength and tone back and then get rid of the brace. Because the best brace for the knee is a conditioned, strong muscle, the quadriceps and the hamstrings. Those are the best braces.
So you think the brace just kind of provides, particularly folks that ski, kind of the mental, psychological support and the feeling of the knee?
For the skiers, I mean, they've shown that it's helped prevent repeat ACL injuries, but these are professional downhill skiers.
That the studies have been done on?
Yes.
Okay.
This is not the rest of us.
Okay. Yeah. Okay. I mean, the bunny hill where Maury hangs out is not going to see a lot of ACL tears, and so
that hurts.
That's interesting.
I think most of the time, brace is just kind of a security blanket, and I think athletes do seem to perform better psychologically, I think, when they have a brace. Not that I would recommend a brace, but I see lots of patients who come in and they swear by their brace. And then I think it is pretty much psychological. I don't think the brace is smart enough as, us are in terms of our knee mechanics and the dynamic stability that we have to control our knees, and the brace just can't do it.
Interesting. So now we're going to jump into another part of the knee. We're going to start talking about the meniscus. And so I need someone to set us up anatomically what the meniscus is and how it performs in its function, and then we'll ask some questions from there.
The meniscus is a C-ring that's on either side of the knee, both sides, the inside or the medial side and the outside, the lateral side. It's a wedge-shaped C-ring, fat on the outside, skinny on the inside, and it helps keep the knee in the right place, and it provides cushion or an increased surface area.
Yeah, it's almost like a bushing or shock absorber inside the knee. It also functions like the hoop on a barrel. So it reduces the stress and the strain on the knee structure and the cartilage in the knee that coats the end of the bone. And finally, it serves as a biological thing. It's like a sponge. It soaks up the joint fluid and then pushes it into the cartilage. So it provides a means for nutrition of the white pearly stuff that coats the end of the bone, too. So
or the cartilage on the end of our bones.
Yeah.
Yeah, okay.
We used to think it was like this expendable piece of gristle. And one of the most frequent operations in the 70s, the most frequent orthopedic operation was to cut open the knee and take out the meniscus that was torn. Take the whole thing out. Because we didn't really know all this stuff that we know now, that it's really an important structure.
So if I have a meniscus tear, what do patients report most frequently when they come to your office with a meniscus tear? What are they going to feel? What are they going to experience?
Howard, what do you think? Pain, I think, is number one.
Absolutely.
And kind of sharp, stabby pain, associated with twisting.
Is it in a particular area?
Generally, it's in the area where the meniscus lives, and the most frequently torn meniscus is the one that lives on the inside of your knee, the medial meniscus, because it's more stuck down, so it can't slip out of the way, so it gets caught between the two bones more often.
We have a call.
Oh, excellent.
Let's go to Sam from Marysville. You're on Health Matters. Go right ahead.
Yeah, hi. I have a question for the docs.
Okay.
I lift a lot of weights, do a lot of bench press exercises, and my shoulder hurts a lot. I haven't been able to lift in the last couple of weeks.
Who wants to handle the shoulder pain?
So, Sam, where is it hurting you?
It's right on the top of my shoulder. There's kind of this bony bump. It's not like at the very end of my shoulder, but...
Yeah, like where your collar... Is it by your collarbone there? Right on the very...
kind of
like
over.
Where a backpack strap would go over?
Yeah, almost exactly right there.
Yeah, well, you have what's called weightlifter's shoulder, probably. And people that lift weights like you and are probably really buff and good-looking like you are, they get this condition. And what happens is you strain, called your AC joint. It's where your collarbone joins the shoulder blade. It's not really in your shoulder itself. Your shoulder is a ball and socket down below that, but it's a joint that helps your shoulder function. And when you're stressing on the bench and pushing and pulling, you can be doing damage to that joint. And then that joint gets damaged and it gets all inflamed and irritated, and that inflammation just keeps going around and around and starts to get the joint sore and swollen, and can even cause so much blood flow to go to the joint that when we take an x-ray of that joint, some of the bone is absorbed because there's so much blood flowing to that area. So the first thing you need to do, Sam, is rest a little bit and sometimes what we do in this condition is we actually give people a cortisone shot right in that joint, and that can cut down that inflammation. And if that doesn't work, believe it or not, what we end up doing is cutting the end of the collarbone off and basically getting rid of that joint, and that gets rid of the pain. So try rest first and a little anti-inflammatory and ice, and change your weight regime a little bit. But it sounds to me like you got weightlifter shoulder. You guys agree?
Absolutely. Thanks for calling, Sam.
Thanks for the call, Sam.
Thanks, Sam.
Okay, so we're just moving right along. We're going to take a break. I have the game Operation in for the doctors to give it a try just to see how good they are at it. And in the meantime, you're listening to the Orthopedic Roundtable with the doctors from Everett Bone and Joint on Health Matters with Maury and Shannon on the all-new North Sound 1380 KRKO Radio.
Health Matters, brought to you by Integrated Rehabilitation Group on North Sound 1380 KRKO Radio.
Welcome back to Health Matters. We don't have much. We have a lot of stuff to do, so let's just get right to it. Give us a call if you have a question. 425-304-1380. We're talking to the doctors from Everett Bone and Joint.
You know, Maury, we've spent a little over half the show on the lower extremities. We're going to get back to meniscus injuries someday.
Okay.
Right now, I want to talk a little bit of upper body type stuff. And what I want to talk about right now is this situation out there. I'm not sure if it's a condition or an injury, but we want to talk about carpal tunnel injuries. And I'm going to ask Dr. Todd Havener, who's a certified hand surgeon, to address that.
All right. Well, carpal tunnel is a very common, it's more of a condition than an injury, and it can occur in an injury. There's lots of different reasons why it occurs, but basically the carpal tunnel is in the palm side of your wrist. It's a tunnel that is pretty small and has a lot of structures that go through it, including the median nerve, which gives you sensation to your thumb, index, and long finger. Your tendons go through there as well. And you can think of the nerve as like a garden hose. And if the nerve gets squeezed or stepped on like a garden hose, the flow of water in a garden hose goes down. And the same thing in the carpal tunnel. If the carpal tunnel gets tight, the nerve just doesn't function very well, and you lose sensation to those fingers. You get numbness and tingling. A lot of times you get some nighttime pain is very common. And there's lots of different reasons why it can happen. Oftentimes it can happen, I think in a lot of our orthopedic injuries in general, occurs just because we're getting older, our blood supply is not quite the same to different parts of our body. And when that happens, our nerves don't function well, our tendons don't function well.
So, can I ask a quick question? Sometimes when I'm on the computer...
Turn your mic on, Maury.
Sorry about that. Sometimes, it's my first day. Sometimes when I'm on the computer a lot, like for about an hour or so, I can feel it like right in my wrist. Is that kind of the carpal tunnel area?
That is, okay. And it may feel kind of like an achiness.
Yeah.
Sometimes, people like to shake their hands out, make it feel better, but oftentimes on the computer like that, your hand's in a position where you're putting pressure on that carpal tunnel, the nerve's getting pinched. Kind of like that garden hose getting stepped on.
You guys want controversy, right?
Yes.
So, Todd, hasn't there been a big study out of Sweden that they put like a bunch of people on computers and had them type away and then monitored their carpal tunnel, their median nerve function, and they found no correlation between those activities and the carpal tunnel symptoms?
That is true, but I think it's the wrist position that you're in when you're typing that promotes the carpal tunnel. It may not be the repetitive typing that does it. Same thing when people are sleeping at night. They put their wrist in a position where they're generally flexed. There's more pressure on the nerve. Their symptoms come on. There's been multiple studies out there in the kind of the work literature that have shown that there's very few work-related type activities that we do that would actually promote carpal tunnel. The main ones being kind of vibrational type activities, jackhammer, around here we see it a lot with riveting and bucking, that sort of thing.
So folks that use their hand frequently throughout the day in that bent or flex position at the wrist are susceptible to this injury?
Yep, that's true. In general, women are more susceptible than men.
Any reason for that?
They're not really sure why. It, again, may be a metabolic thing. It could be an anatomical thing, but that hasn't really been worked out. I think it's more probably metabolic.
I thought I heard somewhere or read somewhere that women during pregnancy sometimes will experience this. Is that
that's true? And the reason for that is during pregnancy, women generally bring on higher volume of blood, more swelling in the carpal tunnel, less space for the nerve.
Wow.
What about smokers, Todd?
Smokers, just in general, that smoking is a risk factor for carpal tunnel. But
that's true?
Again, that's blood supply.
Wow.
Diabetes, too.
It's the amount of oxygen that's in your blood.
Yeah, diabetes affects it. Your thyroid really affects it. Some thoughts of deficiency in B12 can affect it. So
let's just review symptoms again. So with activity, am I going to get numbness and tingling in my fingers?
Just in general, if you're a regular old person, activity probably not going to cause numbness and tingling.
If I have carpal tunnel?
If you have carpal tunnel, oftentimes different type of activities that you may do. Driving is a very common one. Again, that's a wrist position generally. Nighttime is always generally nocturnal. Numbness, tingling, kind of a pins and needles type of sensation is very, very common.
How are you diagnosing this? I mean, what's the procedures?
The most common way is just getting a clinical history of that numbness and tingling. We can do studies where we assess the nerve. We actually can check how quick the nerve can transfer electrical impulses. It's kind of like the electric shock treatment. It's a little bit tantalizing if you're getting it done, where you actually get a little bit of a shock, and they measure how quick that shock goes down to your fingertips. And by that speed, they can determine how well the nerve is functioning. And again, I think, it's very simple to think of the garden hose. If you have it stepped on, the water's not going to flow very fast. Same thing with carpal tunnel. The nerve just does not conduct very fast.
Now, an orthopedic surgeon is not going to do the nerve conduction velocity test?
Typically not. There's some surgeons that may do that in their office. There's newer machines that can kind of do a layman's nerve conduction study, but typically it's a neurologist that'll do that, or a physiatrist. Okay. A physiatrist is a special doc who trains in rehabilitating people with back and spine type issues.
But Todd, do you think everybody needs nerve conduction studies? I mean, I've had patients that it's so obvious they have carpal tunnel. They say their fingers are asleep, it's worse at night. You tap on their nerve in the office and they get zingers. And they're a little bit better when you put them in a brace, but they're still symptomatic. Do you have to send those people to those fancy tests?
I don't think so, no. And unfortunately, there's a lot of insurance companies that will require it. It's when we're talking about medical care and expenses and things like that, it adds a whole lot of extra expense to treatment of carpal tunnel syndrome. If a patient has symptoms that aren't quite classic, it's quite helpful.
Yeah, that's a good point, just in fairness to our neurology buddies.
Yeah, but it's not always necessary. A better diagnostic in terms of how somebody does for carpal tunnel, even with a surgical release, is a corticosteroid injection into the carpal tunnel. Somebody who does well from that typically does very well from a surgical release.
But if you want to bring up controversy, you can talk about what insurance companies make us do that raise the health care price in America, but that's for a whole different show.
That might be a whole other show.
It's more than a round table.
That's a 2-hour show.
That's Congress. That's Congress right there.
That's a closed-in death match.
So now I've had this carpal tunnel, and I have these symptoms, and I've been referred to you, Dr. Havener, and so aside from the injection, surgical approach on this, what are you going to do surgery-wise?
Again, we always try braces and that sort of thing first. But if it comes to surgery, there's two typical ways of doing that. Open carpal tunnel release is versus endoscopic carpal tunnel release. And the idea is you need to make the tunnel bigger. There's a ligament that spans across the tunnel called the transverse carpal ligament. It's basically the roof that kind of keeps everything tight. And in there, what we have to do is release that ligament. It allows the space to open up, and then less pressure on the nerve. The endoscopic way is a newer way in the last kind of 10 to 15 years. There's controversy regarding it a little bit. There's a quicker recovery generally in the first 6 weeks, usually less post-operative pain, less palmar discomfort. The The bad sides or the controversy is that there's thought to be a slightly increased risk of a nerve injury compared to an open release, and maybe potential higher reoperation rate because you're not releasing all of the ligament.
So endoscopic, when you talk about that procedure, you're not making an incision, you're doing the procedure through a scope.
You still have to make an incision to put the scope in, but it's a lot smaller of an incision. The incision's not in your palm. It's more in your wrist crease. You're going in. A lot of times people describe it as laser surgery when patients will come in and say, "Hey, do you do laser surgery?"
Okay.
It's not laser surgery. It's through a scope, and it's a small incision, so it's less morbidity. In that sense, the incision is maybe a centimeter versus 3 to 4 centimeters, and again, the placement is in a less painful position.
And you're doing these procedures outpatient now?
These are all done outpatient.
So show up in the morning, surgery's done at 9, you're home at 11 o'clock, and is that how that works?
Typically, yeah.
Wow. And do their symptoms resolve right away?
Typically, their nighttime symptoms of numbness and tingling and the pins and needles go away right away. The long-term things in terms of how their sensation does or how their strength, if they've lost strength, takes longer to recover. Any nerve that's been injured, when it recovers and regenerates, will regenerate 1 millimeter a day. So compared to where your carpal tunnel is in your palm out to your fingertips, oftentimes takes about 130, 140 days, depends on how long your fingers are.
Then they put you in those bowling braces, like the bowlers use.
I think that's one of the key things about endoscopic versus open and treatment differences. With the open way, we used to brace people. We used to put them in splints. We used to kind of immobilize them. With the endoscopic technique that we do now, being less invasive, patients initially have less pain. I get my patients moving right away. I don't put them in any kind of brace. I give them exercises from the day of surgery to start moving their fingers, their wrist, to keep things from scarring in. I think a lot of times that can be the biggest problem.
So from the sound of it now, these days, there's no bracing anymore. You have surgery. You're up and about, right? Is that how it's working?
I mean, in general, we're mobilizing people sooner because we're fixing things more effectively and stronger. The other thing that I think you can pick up from our conversation is the positive impact that scopes have had on orthopedics. That whole knee stuff we were talking about earlier, that used to be done through a big old incision. Now it's done through a couple poke holes because we can use this arthroscope using, fiber optics and really cool computer chips that give us images on a flat screen in the OR, and we can look inside the joint or we can look inside the hand and operate through much smaller incisions and much more precisely. It's made a really positive impact in getting people better.
And quicker recovery time, too, then, right?
A lot less invasive.
Right. Yeah.
So, Dr. Havener, I'm an electrician, let's say, and I come to you with carpal tunnel and you do the procedure. When can I expect to be back to my job at 100%?
100%, I would say by about 6 weeks. I typically limit patients to, I say, lifting 10, 15 pounds for the first 6 weeks. So electricians, as you know, do lots of crimping, lots of drilling, that sort of thing. By 6 weeks, typically that pillar pain is feeling pretty good. Could take as long as maybe even 12 weeks, but by 6 weeks function quite normally.
Todd, is it fair to point out, though, that the outcome, particularly when you're talking about nerve surgery, is really variable? Because it's not just variable because of how good the surgeon does. Todd does a great job on every carpal tunnel, I know, but a lot of the outcome depends on how badly that nerve has been squished, how long it's been squished, and what kind of nerve that patient was born with. And those things really determine the outcome, too. So, it's you may have people out in the listening audience that say, I had a carpal tunnel release and, I still have some numbness and tingling. And other people would say, I had a carpal tunnel release and, I was cured. It was gone. And that's sort of the nature of the beast.
Yeah, I think you can say that with almost all of our injuries. No two injuries are exactly the same.
Good point.
And the nerve injuries can be quite tough, and there's all huge spectrum of severity, and no two patients are the same.
So when you're in there looking at that nerve, if that nerve is inflamed and irritated, what does it look like? I mean,
usually the tissue is quite red. The blood vessels are, I guess, more prominent than normal, and it's often swollen. Those are the main things I see.
Time's up.
Time is up. Yeah, this has been awesome, and we have a ton of questions.
We need to talk to Dr. Barker about bunions.
I didn't even ask him. I wanted to know what kind of music they listen to when they do surgery, but we're gonna have to save that for another time.
Bring your own. Want to hear Todd's music?
Okay.
Bring your own music.
I'd like to take a minute wrapping this up and thank Dr. Barker, Dr. Wertheimer, and Dr. Havener for taking time out and sharing your knowledge. Quite impressive.
It was awesome, you guys. It was really cool.
That was fun.
If you want more information on how to contact the docs, just go to irgpt.com. All the information about Everett Bone and Joint is on there, and they will. That's where you can find it. Join us next month, Monday, August 10th. We do it twice a month now, between 6 and 7, for the next edition of Health Matters. I want to thank our producer Karen Morick, Tom Lafferty, I'm Maury Eskenazi.
I'm Shannon O'Kelly. Be healthy.
Health Matters. The content of Health Matters is intended for general informational purposes only and is not a substitute for medical diagnosis or treatment. Individuals with health problems should always consult with their healthcare provider for professional medical advice, medications, or treatments. The views expressed by show hosts and their guests are their own and are not necessarily the views of Integrated Rehabilitation Group or this station. We encourage you to seek professional advice or